All right, welcome everyone and good morning and welcome to Josh Kotler, our doctoral candidate's capstone presentation today. Last night, we actually just onboarded officially and welcomed 7 new OTD students into our program who were joining us all over the country and all over the world. And today we have another celebration, bookending, which is Josh's capstone presentation. Both are actually, we see as new beginnings. This doctoral capstone presentation is really a day of celebration, of celebrating growth, of celebrating personal and professional development, and 2.5 years of exploration to fill in a very particular gap in clinical practice. Our doctoral students and our graduates are truly changing practice. The graduates that we've had are publishing papers, continue to publish papers, present at conferences. They are leaders and administrators in therapy departments and hospitals and teaching in occupational therapy programs. And today marks sort of like a new milestone for Josh, who not only became a new dad last week, but also entering a new sort of period of the workforce to change practice. And Glenn's showing us Baby Liberty right there. So before I turn it over officially to Dr. Glenn Gillen, our program director and Josh's mentor, I just want to set our house rules for today's activity. So Josh is going to be presenting for the first 30 minutes of the time and presenting his doctoral journey and his capstone project, followed by 30 minutes of scholarly discussion. This 30 minutes will be chunked into 2 sections. The first 10 to 15 minutes will be solely devoted to Josh's capstone committee, who are Dr. Glenn Gillen, our program director, and his doctoral mentor, and Dr. Daniel Geller, his capstone reader. After that, after the first 10 to 15 minutes, we will open the floor for conversation and scholarly discussion for the public. In doing so, we will be moderating it in terms of just taking turns. So please use the raise hands function on Zoom so I could call you and ask your question, give your feedback, and send warm greetings to Josh. All throughout the presentation, please keep your cameras on and your microphones on mute until we call on you for the scholarly discussion if you want to ask a question. I'll turn this over now to Dr. Glenn Gillen.
What is to say? I met Josh. I've heard about Josh for a long time, actually, because we have a long-lasting relationship with Mount Sinai. And I met him right when he was admitted to the program, and he took a continuing ed course that I was teaching. And it was an intense 5 days. And just based on his commentary in that course and his dedication, I knew the admissions committee did a really good job in terms of picking him to join this program. Being an OTD program, I want to talk about Josh in terms of his occupational roles. So one, he's I shouldn't say was an outstanding student, because I think Josh is someone who's going to embrace lifelong learning, actually. So will continue to be an outstanding student. He's a master clinician in terms of neurology at Mount Sinai. Still an outpatient, Josh? I forgot if you switched.
Acute care now.
Acute care now, okay. Yes, I do remember that, actually. In terms of other occupational roles, he's a dog daddy, and now he is a person daddy to Liberty Rose. He is an amazing husband who, just in case people don't know, because he was in a high-risk area, actually moved into a vacant apartment on the floor where he and his wife live. And it made me so uncomfortable. I thought he was kidnapped at one point because there was nothing in the room. And I remember saying, if you need our help, blink twice, send somebody. He's been a pleasure to work with. Everything gets turned around immediately. Our phone calls related to this project have been very succinct and organized, and it's just been a grand pleasure. And I can't wait to see the presentation again and what Josh is gonna do going forward. I know amazing things are gonna be happening with him.
All right, thank you. Josh, we're ready for you.
Okay, thank you, Lennon, and thank you, Glenn. That was very kind. Those kind words mean a lot to me. I'm going to go ahead and get started. Thank you everybody for coming this morning. I'm going to start talking about my Capstone project, which is the development of an intervention program to target sustained and selective attention deficits in adults with stroke. So attention deficits are a common cognitive impairment after stroke, and these deficits can negatively impact rehab outcomes. When we talk about attention, it's defined as maintaining focus on meaningful and relevant information when multiple stimuli are present at the same time. Attention is not a unitary entity, but rather includes perceiving individual items, also known as focused attention, concentrating or sustained attention, avoiding distractions, selective attention, shifting focus or alternating attention, and responding to multiple tasks simultaneously, also known as divided attention. So these attention deficits have been linked to poor functional outcomes during occupational performance for people with stroke. Current research suggests that there are limited effective interventions for targeting these attention deficits in people with stroke. However, treatment of these deficits is necessary due to the negative impact it can have on function and quality of life. So overall, this Capstone project focuses on the development of an intervention program to effectively treat sustained and selective attention deficits. And my Capstone project really focused on four key essential points, which was the development of a theory-guided practice model for improving attention in people with acquired brain injury, the design of a functional measurement tool for assessing sustained and selective attention. I conducted a scoping review to identify evidence-based interventions for treating attention deficits. And overall, this led to the design of this intervention program. So looking at the doctoral program, it started with the program development artifacts and the advanced application of theory to practice course. And in this course, I was able to develop a theory-guided practice model, which is called the Intervention Strategies for Improving Generalized Attention using the Ecology of Human Performance model and the neurofunctional approach for patients with acquired brain injury. So just to talk about the Ecology of Human Performance model, this model highlights four key constructs, including the person, task, context, and performance. The person and context relationship is transactive and dynamic, and this transaction must be taken into consideration when facilitating performance during meaningful tasks. So if OTs evaluate an individual performance without considering the context of the performance, there's a greater risk of interpreting behaviors inappropriately. And EHP really supports a client-centered approach through performance of meaningful tasks in the natural context. Intervention strategies that help guide OTs using the EHP model focus on establishing and restoring skills, altering the environment, adapting and modifying, preventing and creating. And using this model in stroke rehab, OTs can promote client-centered practice through a combination of all of these treatment strategies. The neurofunctional approach to rehab is an occupation-based model with an emphasis on learning by doing. So NFA focuses on performance and participation of clients to develop cognitive skills necessary to engage in preferred tasks. Using NFA, OTs can facilitate improved performance through errorless learning and task-specific practice. Errorless learning involves cueing or implicit guidance from the therapist to prevent the propagation of errors. So practice is the repetition of a behavior. An identical response is provided to an identical stimulus. The emphasis on repetition and training of functional skills will allow clients to develop routines and habits, which can assist with transfer and generalization to multi-contexts. Training real-world skills, which are important to clients in their social and cultural environment, are seen as advancing the person's personal goals. It can increase motivation and participation to engage in these tasks. And overall, through practice, using this approach, habits will develop and increase the likelihood of learned behaviors to occur. This essential elements image really puts together the theory-guided practice model, where the goal of it is to improve generalized attention during occupational performance in patients with acquired brain injury. This will be achieved by increasing motivation and participation. So identifying important roles and needs in the person's life can increase motivation to participate in occupations. And when individuals are actively involved in the therapeutic process, motivation will likely increase. Allowing the person to act as the decision maker in the process will enhance participation, and OT should identify meaningful tasks through clinical interview of the person or family in order to establish an intervention plan that is meaningful. Also implementing specific strategy training. Strategy training relies on the person adopting new thinking routines that support his or her occupational performance. Enhancing self-awareness of deficits and development of metacognition are essential for implementing these strategies. Once self-awareness of deficits is established, therapists can implement these strategies through directly teaching them or facilitating the use of strategies during performance. And the therapist providing feedback can assist the person in identifying problems in performance. Self-generating strategies through feedback or directly teaching them will be the keys to improving occupational performance. Also using task-specific practice with errorless learning in the natural context. So practicing these skills, using the whole task practice can increase automaticity during task performance. This skill habit training can help people make needed functional behaviors automatic. Altering and adapting the task or environment. So altering focuses on identifying contextual features that may support an individual's performance. And altering the environment does not make changes to the context or improve skills, but rather identifies a match between the person and the context transaction. Adapting or modifying approach allows a therapist to adapt or change the contextual features to best support the performance within the frame of the person's skills and abilities. And overall, reestablishing and developing habits and routines will develop, like we said, automaticity during occupational performance, which is essential for reestablishing and developing these everyday habits and routines. Guiding treatment using these 5 essential elements may enhance occupational performance for people with functional cognitive deficits post-acquired brain injury. Moving on to the next professional developed artifact in the neuroscience of cognition course, I was able to write up an in-depth analysis of a 61-year-old male who had a right-sided CVA following a middle MCA or a CVA of the middle cerebral artery. So I explored the structural involvement of the middle cerebral artery in this course and the lobes of the brain in which it supplies, the frontal, the parietal, and the temporal, in order to identify areas of the brain that may have been damaged and the potential deficits that resulted from this stroke. Various assessment tools were used to evaluate functional cognition of this client. The cognitive deficits that were present on assessment were impaired attention, memory, left unilateral inattention, and organization. These deficits impacted the client's ability to successfully engage in functional tasks and preferred tasks, including cooking and navigating in the community to just leisurely walk with his partner. Interventions in the clinic focused on task-specific practice of these preferred occupations, altering the environment, and specific strategy training. So the scanning strategy that was used was the lighthouse technique to improve scanning, as well as the implementation of schedules or daily planners for organization. And these were some strategies that were helpful to enhance occupational performance. Altering the environment to provide cues that help remind the patient to engage in certain tasks and incorporate their affected side was also helpful. And repetitive practice of these tasks in the natural environment, such as walking the community, navigating the grocery store, and just performing functional tasks was effective intervention for improving function. The encouragement and implementation of an assisted device to cue the patient to incorporate their affected limb was also an effective treatment strategy to help overall attention and the inattention to the affected side. Moving through this doctoral process to the educational and continuing education artifacts, I was able to develop a teaching philosophy statement that really helps guide my teaching practice. And in the methods of teaching course, I developed this teaching philosophy statement, which was best supported by the philosophies of progressivism and social reconstructivism. So I believe in encouraging learners to think with effectiveness in an environment that focuses on experience, problem solving, and growth. Progressivism is an educational philosophy that promotes learners to think with effectiveness, to analyze, to criticize, and to select among alternatives. The progressivist educational model focuses on experience, problem solving, growth, and this attempts to teach subject matter in the traditional sense while allowing exploration through experience-centered curriculum. The other, social reconstructivism is another philosophy I would use in conjunction with progressivism. This shares the similarities with progressivism, however, takes a more collective and radical path where institutions become leaders in advocacy and social reform. So instruction and discussion using this will be guided by real world and relevant cultural and societal issues. Curriculum would feature experiential learning, collaborative and community-based learning, encourage problem solving, activism, and advocacy. So using the progressivist educational philosophy with social reconstructionism aligns with my learning and teaching style. I really believe the focus of teaching should incorporate personal experiences of both the teacher and the student, while relating these experiences to the material in order to increase motivation and really assist and guide students in making connections. Progressivist and social reconstruction theory encourage problem-solving, growth, and interactive group environment. This can help stimulate the learning process and encourage students to make connections through exploration and growth. So really the ultimate goal of my teaching philosophy is to allow students to really challenge and learn from each other in order to advocate for change. And this change includes an ethical and more inclusive society that focuses on social justice, where all people really have equal rights and opportunities. The next artifact that contributes to the educational and continuing educational piece of my doctoral program was the A1 certification. And this certification is the Arnaudotter OT-ADL neurobehavioral evaluation that I was able to take with Glenn. And this assesses cognitive and perceptual dysfunction through ADLs and mobility. So this 5-day training course for OTs basically is on the theoretical background, the administration, scoring, and interpretation of the A1 neurobehavioral evaluation instrument. And I continue to really use this instrument in the acute care setting to evaluate cognitive perceptual dysfunction through the observation of ADL and functional mobility tasks in patients with various neurological conditions. I think it's a great observation-based, performance-based assessment. And this program really taught me that performance-based testing for OTs in particular is really where we should be moving in the field to get the best assessment and make the best treatment plans for our client population. Moving on to my evidence-based practice artifacts, I'd like to talk about the advanced evidence-based practice course, and I was able to conduct a scoping review titled Effective Interventions for Improving Attention Deficits in Adults with Stroke. And as you can see, here's the Prisma chart. Due to the negative impact that attention deficits can have on overall function in people with stroke, it's important for OTs to be aware of effective interventions that can improve attention. So basically, this scoping review really strives to identify current interventions that have demonstrated positive outcomes for improving attention. And multiple bibliographic databases were searched, PubMed, Ovid, and the search results were imported into Covenants and screened for inclusion criteria. Based on eligibility criteria, 8 articles were included for full data extraction using an AOTA evidence table. Specific interventions were clearly identified, and all interventions targeted a variety of cognitive impairments with specific mention to attention. Outcome measures for attention were used in all included studies, and the results for each article were clearly charted. So while all of the studies included in the scoping review demonstrated positive outcomes for attention, there were limited studies specifically targeting attention deficits. So in conclusion, the scoping review found that cognitive rehab interventions have shown some level of effectiveness for treating attention in adults with stroke. However, there were limited studies really only targeting attention deficits. Most of the studies included in this review used cognitive rehab interventions for treatment and really targeted a variety of cognitive and or motor cognitive deficits with specific mention to attention. I decided to submit this manuscript to AJOP for publication because this journal highlights the contribution that occupational therapy can provide to the healthcare system and is committed to publishing quality research with strong evidence for OT practice. So there continues to be a critical need for evidence on effective interventions in various practice areas within the OT domains. And this scoping review identifies intervention strategies for improving attention in adults with stroke. In this course, the evidence-based practice course, I was able to use this scoping review and write a mini critically appraised topic paper. And this mini CAT was accepted for poster presentation at the 2020 Janet Falk-Kessler Distinguished Lectureship at Columbia University. So based on the results of my scoping review, OTs should consider implementing rehab interventions such as attention process training, computer cognitive training, aerobic exercise, and virtual reality simulation. This review suggests that these interventions may have a positive impact on attention, which may translate to improved attention during performance of real-life functional tasks. And throughout the literature search, I found that many articles targeting unilateral inattention in people with stroke. So I came across an abundance of research on unilateral inattention, but not attention in general. And unilateral inattention is characterized as an attention deficit and is defined as the inability to direct attention to the contralesional side of space, which commonly occurs following a right hemispheric stroke. One intervention that was commonly used was limb activation training during task-specific ADL tasks. And this was an effective intervention for improving unilateral inattention. So since it is a widely considered an attention deficit and research has identified limb activation training as an effective treatment, limb activation training may be an effective treatment for improving overall attention deficits in stroke. This hypothesis presents an opportunity for future research to be conducted using this training method during functional task performance as an effective intervention for targeting attention deficits. Going to the next evidence-based practice artifact, in the instrument development course, I was able to develop an assessment tool titled the Online Shopping Test of Sustained and Selective Attention. And this is a functional assessment tool, a performance-based test that focuses on assessment of sustained and selective attention during occupational performance of a common IADL task. So the online shopping test of sustained and selective attention is a proposed tool to assess these attention deficits in adults with functional cognitive deficits following a neurological injury. So in short, the OS-TOSA will assess sustained and selective attention during performance of a standard online shopping task. I chose an online shopping task because a large portion of the global population is participating in online shopping. And I felt that this function-based assessment can provide clinicians an opportunity to interpret a client's current level of cognitive functioning during a task that is relevant and meaningful to their everyday life. The OS-TOSA is a non-standardized assessment tool evaluating a person's ability to attend to all steps necessary in completing an online shopping task. So scoring was based on a percentage of the tasks completed without requiring cues for remaining on tasks, and also the type of cues required for remaining on task. It was basically a 4-point scoring scale. 4 remains on task without requiring cues, general cue for remaining on task, or a 3, 2 specific cue for remaining on task, or 1 a physical or gestural cue for remaining on task. The last artifact for my evidence-based practice courses were my grant proposal. And this was in the grantsmanship course. My grant proposal would be submitted to the Brain Injury Association of America. And this seed grant funds up to $25,000 to support clinical investigations in brain injury rehab. So once my initial pilot study is conducted, This seed grant proposal will be submitted in order to receive funding for a larger intervention study using limb activation training for improving attention in acquired brain injury populations. The three aims of this grant were to test the immediate effects of limb activation training on sustained and selective attention deficits, to provide an evidence-based intervention tool to clinicians treating people with acquired brain injury, and to improve the quality of life for people with acquired brain injury by increasing their attention during occupational performance. All of these artifacts led to the Capstone project, which is the intervention program with the use of a treatment technique called limb activation training during performance of a commonly performed functional task. So limb activation training is an intervention used to call attention to the affected limb in individuals post-brain injury. This intervention program will use a limb activation device, in this case an Apple Watch, to call attention to the affected limb in order to cue the participant to incorporate that limb and cue them to attend to back to the task. This will be done during a standard grooming task, and the reason I chose an Apple Watch is because it is accessible to the public, and if effective, can be used in real life task and easily accessible to the greater population. The limb activation device, as I said, will provide a cue to the participant to remind them to maintain their attention during a functional task, or will redirect their attention back on task. So it will be worn on their affected limb, and the device will provide an auditory and tactile cue each minute that the participant is performing the grooming task. So the OT will provide a verbal cue if the patient is unable to redirect their attention back on task when the device rings. On April 1st, 2020, an institutional review board at Mount Sinai School of Medicine, in accordance with Mount Sinai's federal-wide assurances to the Department of Health and Human Services, approved the following human subjects research study: limb activation training for improving sustained and selective attention during occupational performance in adults with stroke. Unfortunately, when this IRB was approved was during COVID-19, and all human subject studies at the Mount Sinai Hospital were placed and continue to be placed on hold indefinitely. While this pilot intervention study received IRB approval from the Institutional Review Board, I was unable to obviously conduct it at the time, and still unable to. However, once human subject studies resume, this pilot intervention study will be carried out at the Mount Sinai Hospital on the acute care stroke unit. My Capstone project is the development of this intervention program, and this pilot study designed to be carried out once human subject studies are restarted pending this COVID-19 crisis. The title of this pilot study would be Limb Activation Training for Improving Sustained and Selective Attention During Occupational Performance in Adults with Stroke. So the purpose of this early exploratory pilot study is to identify this as an potential effective intervention strategy for improving these attention deficits in people with stroke. Like we've said, attention deficits have been identified as a barrier for people with brain injuries that limits their ability to successfully perform everyday tasks. And this pilot study will help determine if this treatment technique might be used as an effective intervention for improving these attention deficits and ultimately improving occupational performance during a standard functional grooming task. The participants in this study will be people ages 18 and older with right hemispheric stroke demonstrating attention deficits. Subjects included will be enrolled in the acute care inpatient brain injury units at the Mount Sinai Hospital, and participants may demonstrate various sensory motor deficits of the affected limb, however, must have a trace muscle grade in the shoulder in order to activate the affected side during this training protocol. The design of this study will follow a case series design using approximately 5 to 10 participants with sustained and selective attention deficits post-stroke. And these attention deficits will be assessed using subtests from the test of everyday attention. This is a valid and reliable assessment tool. Subtests of the test of everyday attention will be administered to participants in the study prior to implementing this treatment protocol and immediately following the treatment protocol using a parallel version of the test. The grooming activity will involve washing your hands, face, body parts, brushing your teeth, combing, brushing your hair, shaving, donning deodorant, and makeup as necessary or applicable. And like I said, a parallel form of the test of everyday attention will be administered following the limb activation training session. The procedure, so participants will participate in this 30-minute session of limb activation training during a standard grooming test. And like I said, pre and post test of the test of everyday attention. So future research directions. And as you can see in this functional mobility task sheet, my client is wearing the Apple Watch on her left upper extremity. Future research directions include the need to conduct this pilot study using this intervention strategy in order to identify it as a potential effective treatment for improving sustained and selective attention. So once this pilot study is conducted, my grant proposal will be submitted to the Brain Injury Association of America and hopefully receive seed money to conduct a larger intervention study using this training with a larger sample size across multiple ADL domains. So eating, grooming, dressing. And I believe this research is needed to continue investigating effective treatment methods for targeting sustained and selection deficits in order to improve functional and occupational performance in adults with stroke. Really moving to the highlights of the doctoral program, that's the overall sequence of my artifacts, and then the leading up to my pilot study and the intervention program that was developed. The overarching goal of this OTD program is to deepen the knowledge within a specific area and its application to practice, to pursue evidence-based practice as a clinician, to apply research methodology, to answer a clinical question and apply clinical reasoning to practice at an advanced level. Like I just spoke about, I was able to develop a theory-guided practice model, implement that practice model, and write up a clinical case study. The development of my teaching philosophy statement, the A1 certification training course, my scoping review to be submitted to AJAT for publication, writing up a mini critically appraised topic paper, and being accepted at the Janet Falk Kessler lectureship, the development of a performance-based test and assessment tool, the IRB approval for my pilot study, and my grant proposal to be submitted following the implementation of this pilot study. Really, as I reflect on this doctoral process, I believe it really has enhanced my knowledge and clinical skills in the area of functional cognition for patients with various conditions, but in my focus area, neurological conditions in the rehab setting. I really have gained a tremendous amount of expertise to implement interventions guided by theory, select appropriate functional outcome measures, and provide mentored guidance to students and faculty. This program truly has molded me into a leader in the field of occupational therapy, both in the rehab setting and in the classroom, that will really help my patients and educate the future generation of OT professionals. I'm looking forward to completing this pilot intervention once human subject studies are reinstated and the hospital begins allowing them to continue. This will be the next step in my doctoral process, as I'm eager to continue exploring interventions that may help improve functional outcomes within my patient population. Really, overall, this doctoral program has provided me with the tools necessary to be an agent of change in the field of occupational therapy. I really look forward to using these tools in clinical practice and in the academic setting to help my patients, colleagues, and future students. I'd really like to take a moment to acknowledge really thanking all the Columbia faculty that has helped me throughout this process. They've really guided me and made me an expert and in my field and my practice. A special thanks to Dr. D, Dr. Dawn Nilsson, Dr. Lennon Graho, my doctoral capstone reader, Dr. Dan Geller, and of course, my mentor, Dr. Glenn Gillen. I continue to work as a lab instructor with Dr. Geller in his BizDiz course for the master's level Columbia students. I'm grateful for his mentorship in the classroom and for taking the time to review my capstone artifacts. Dr. Gillen, I don't know what more I could say. He's provided me with mentorship and guidance throughout this doctoral program that is priceless, and I'm so grateful for him. I'm honored to have worked with him. I'm truly grateful for his guidance and mentorship throughout this process. And I really hope to continue collaborating with him on future projects, as well as the whole Columbia staff and faculty. I'm proud to be a part of this family, and I am really grateful for this experience. And there's really nothing more I could say, but thank you to the whole faculty. And I'm really looking forward to the future and what my career has to hold. So thank you everybody for coming today. And I'm open to questions.
Josh, I'll ask you to end your screen share for now, and then we'll allow the first 10 to 15 minutes for Josh's committee for questions. So Dr. Geller and Dr. Gillen.
Unmute Dr. Gillen.
Unmute, please.
Do you want one of us to go first or just ping pong back and forth?
Yeah, that's fine. Yeah.
Ping pong?
Either works, yeah.
Okay. Josh, let me just give you another reaction shot. There you go. I will say you emulate your teaching philosophy really well. So you've really adopted what you developed in that methods of teaching course. So congratulations, you're an outstanding teacher. And this was really organized and clear as a bell. One question I want to ask you, and this might have come up in your neuroscience course, the neurologic mechanism of left limb activation in terms of activating the left limb to increase attention. Can you talk a little bit about what that relationship is between moving the left side and improving definitely unilateral attention, but hopefully sustained and selective attention?
Yeah, so, because as I said, left inattention is classified as a unilateral attention deficit and can be classified as an attention deficit. And while I know that possibly these two deficits, attention and unilateral inattention, may be slightly different areas of the brain, what I've learned in this program is that the brain, especially in my neuroscience cognition course, is that the brain is dynamic and the brain is always working together, and the different parts of the brain are always working together, and we're never going to see a clear-cut deficit because the brain is so dynamic and always working together. So my thought process there is that if unilateral inattention can be effective can be targeted by activating that left limb, by activating that left limb, it can also re-engage and have the client reattend to the functional task and increase their attention to what they're performing by giving them that cue and activation to the left side to help them kind of refocus and shift their attention back on task.
Thank you. I'll have one more quick one, and then I'll pass to Dr. Geller and we can go back and forth. I don't know if everybody knows the outcome measure that you're using. Can you just give people a little bit of, and why you chose it? I think I know why you chose it, but.
Yeah, so the test of everyday attention simulates functional tasks. And when I say simulates, it's, a very big stretch. I think one of the issues I was coming up with Dr. Gillen is that there isn't really a functional outcome measure for attention, and that this was the closest gold standard attention assessment outcome measure that we can find. It is 8 subtests targeting various different areas of attention. So there's like an elevator counting test. There's like listening to bings and kind of counting for an elevator. There's various different components to the test. And really what this process kind of also highlighted for me, as I said earlier, is that, this was the best gold standard outcome measure for attention that we can find. And I think that what I wanted to highlight is that, we really do need more function-based assessments in our field of OT that will target different areas of functional cognition. Because while I'm using this test and it is effective and reliable and valid, I think that there could be better tests out there that could maybe provide a better assessment for our client population.
Okay. I think, and I agree, I would love to work with you going forward. Maybe we can figure out how to quantify attention during the grooming task in terms of number of distractions, pauses in performance, and maybe we can use the Catherine Bergego scale as a model. Because that is a really nice performance-based assessment for unilateral attention. So, okay, but you're right, that's what's available right now. So thank you. Dr. Geller, I'll throw it to you.
Okay, so congratulations, wonderful organized presentation. It flowed very well. I just had a couple, also I just wanted to say, when we were talking about your teaching philosophy, I just really thought about you in the classroom and how you do use your personal experiences in teaching the MS students from what I've seen. So I think it's great that you're using you're using that type of theory to really use your own practice to teach. So congratulations on that, and it's a pleasure working with you and teaching with you. I just had a couple questions. In terms of your interventional study, I know you were talking about how the lat was more for unilateral neglect, but now you're looking to see it more generalized attention. So with your population, are you distinguishing someone with unilateral neglect versus generalized? Because I know you're saying they're right CVA, so are you distinguishing one versus the other when you're pulling in patients, or are you taking people with unilateral neglect, or does it matter?
I was gonna just I was gonna pool them together, and they really have to identify deficits on the test of everyday attention in order to qualify for the study. So they have to demonstrate attention impairments on sustained and selective attention components of that test, but they could have unilateral inattention as well.
Okay, so you're gonna, okay. Also, just in terms of, can you just tell me a little bit about, in terms of your grooming test, I know you took the A1, so was there a specific way you were setting up the procedures for the grooming when you're doing it, or was it more, basically I'm thinking about like items put on, in A1 we're taught that you put items certainly. Is there a standardized way you're doing that for your intervention, or not really?
So, I chose grooming because I felt like it is the most practiced ADL that it is conducted in the acute care setting.
Mm-hmm.
And I felt, that a grooming task can be done seated at the sink or standing at the sink. So I felt like it was more universal to different levels of functioning. In terms of setting up the grooming items, I was going to set them up on the sink kind of in the same order for each patient, but with no specific, not avoiding putting things on the left, but kind of throughout the whole sink area.
Okay, I was just wondering if there's a standard, but there is a kind of more of a standardized way you'll be doing it.
Yeah, we'll keep everything generalized the same structure, but not, just start putting things on the right or just putting things on the left.
Also, can you just also, one last question just about the, so you're saying they needed trace elevation, correct?
Yeah.
Now, what was the reasoning for that in terms of?
That's the standard requirements to implement the limb activation training protocol.
Oh, in general.
So I wanted to kind of stay consistent with that treatment, with that protocol's, guidelines.
Okay, that's what I'm, okay.
Leonard, do I have time for one more quick one until we open it up? Okay. Josh, I remember the day you called me and you said, oh, I have IRB approval, but attached to that was a letter saying I can't do it because of COVID, like in the same envelope. But I also see that you were using the Apple Watch in that slide for the functional mobility. So I know you weren't conducting research, but anecdotally, did you see any changes in that? I think it was a woman you were walking with, actually.
Yeah, so I did try this with a few patients, and what I noticed is that the cue provided by the watch not only helped identify them to incorporate their affected limb, but also kind of just the cue, the vibration of the watch or the auditory cue helped kind of reshift their organization and get them back on focus during the task. So that was really my main thought process, that if this cue can help them engage their affected side, why wouldn't it be able to cue them in a functional way, right? We all wear Apple Watches throughout their day. If they wore this device that was able to cue them to kind of give them a quick reminder and a strategy to be like, hey, I'm supposed to be doing something else right now, then it may be effective in during function.
Thank you.
Anything else, Dr. Geller, Dr. Gillen?
I might jump in later, but I'd like to hear from the people.
Sure. I have one quick question and then I'll open it up for others. So Josh, Dr. Gillen actually mentioned this as a future plan for sort of expanding or developing an assessment on attention. And I remember when you were in the measurement class, when you were sort of attempting to draft that online shopping assessment tool, we had that same conversation about how difficult it is to sort of parameterize attention and figure out how do we put a qualitative and quantitative measure to subtle nuances. And really, you know, the first lecture in the class is how to sort of link a latent variable, something that you don't really see and couldn't really measure, to an observable variable. That's something that you could really measure. Talk to me about just how knowing how difficult it is to quantify a particular skill or trait or ability. And now that you have a deeper understanding of that through the theory course, how has that changed the way you choose your assessments in practice and how you view the assessments that you use in practice?
Yeah, so it's very, you know, it's very hard. What I've learned, I think, in order to get kind of the best measure of what we're looking for from our client population, we need to, you know, have standardized, valid, and reliable assessment tools that can provide, you know, objective data that will help us kind of identify deficits and show improvements with intervention. But, you know, overall, I think that as OTs, using assessments that are kind of, like we talked about, performance-based, that will really help us use our observational skills to identify barriers that people are having during occupational performance, and then using those observational skills to kind of implement strategies and come up with a treatment plan. But like you said, yeah, it was very hard for me to kind of take my assessment tool and really focus in on just those two elements of attention. It was very difficult to really navigate such a task that is really kind of a broad area of cognitive skills to really just focus on attention. But, you know, I think that working with you in the measurement course, I was able to kind of do the best we can in terms of kind of getting a good score and measurement for attention while doing that online shopping task.
Thank you. I'll open it up now for comments, feedback, and questions. Phyllis?
Oh, Josh, it's so nice to see you. And I was so happy to be part of this process with you because we started in some of our classes together. So you did a fabulous job. And this is a topic I've always been really interested in. I know, and Josh and I shared a lot of our work together also. Two questions. One is about, I'm wondering what your thoughts are about the dominance factor and how that may play into the limb activation. Because I've always been plagued by that working with patients in stroke recovery. There's always going to be a difference. People who are extremely right-handed, vice versa. I wonder what your thoughts are about that or what you might see.
Yeah, that's a great question. I find that when I go and evaluate a patient and I ask about hand dominance and their dominant hand is affected, they kind of look at me and laugh like, what do you mean? What's my dominant hand? Like now it's my left hand. So, you know, that's a great question. I think that it can definitely play a role in how they implement their limb. But ultimately, if it is their affected side, is their dominant hand, regardless of what their dominant side is, we want to retrain them to use that affected side. So I think it would benefit regardless. And yeah, their performance may be slightly, impaired due to that not being their affected side, but the importance is still there, I believe.
Yeah, I agree
Phyllis,
with you.
can I
I just,
piggyback on that for a second?
sure.
So what I always think, I agree with both of what you said, but I also think, we always say the right hemisphere is dominant for attention. But if you're if you're a lefty, are things different? Like, is your brain circuits different? Is the left side then dominant for attention? That's what I always get hung up on, because we know the motor system is switched, but are the other systems switched? Because we've all seen people that have right hemisphere dysfunction and they're aphasic.
Right.
How does that happen?
Right. Yeah, and I'm just, I'm just always curious about how people, because some people are very right-handed, left-handed, and its impact on attention, which is what you're really looking at, because, it's just always perplexed and, always wondered about it. My other question was just about your measurement tool, because I remember us talking about this also. And I'm wondering if you thought, because you're looking at both parts of selective and sustained attention, if, do you have them like subdivided, like different components of the task that you can get like sub-scores? Because sometimes I think you can then tie that into goals or treatment interventions that may be geared more towards selective or more towards sustained attention.
Definitely. We talked about that, and I think that it was just something that I was considering making subtests. The reason, and we spoke about this, I chose sustained and selective attention is because A, sustaining the attention to the shopping task, and B, avoiding all those distractions of like ads on the side of the screen and all that. So I thought that those were two good measurements, but that's a great point to kind of separate them into subtest areas and score each one individually.
Yeah, I know Dr. Grajo helped me also set up the subtest, because then you have, two different areas that can also demonstrate change in either one as people are progressing, just one score for an objective measurement. But great job, and I'm really excited to see where you go with this, and congratulations again.
Thank you. Dr. Falk-Kessler.
Hi, Dr. Kotler.
Hi.
I think I'm the first person, and I'm shocked that I'm the first person to call you that.
I don't think you're supposed to say that yet, but that's okay.
No, I'm saying it. I'm saying it. Terrific presentation. It really was. And I'm especially in awe of how you did this. This part of the studies sometimes can be the most challenging just because of the nature of a capstone and of your capstone project. And to do it while COVID hit hard, to do it while your wife was pregnant and you had to move out for safety purposes is just incredible. And what you've done, I'm just in awe of your ability to accomplish this, and with such attention. I mean, I hate to, and dedication. My questions are not neuro-based. I'm interested in, I understand your choice of the Apple Watch. I was having some computer problems, so I might have missed a piece if you already addressed this. But the clients or the patients that you were able to observe, did they own the watches? Did you supply the watch? Your thoughts on individuals? I mean, Apple Watches are readily available, but now I'm putting my occupational justice hat on. A lot of people can't afford them.
Yeah.
They are expensive, or they don't have, there are a lot of issues with it. So I'm wondering about your thoughts specifically on the watch and alternatives for cueing purposes when they leave, when they are out of the acute setting.
Definitely. I use my Apple Watch, and I wiped it down with the wipes in the hospital first for infection control. And I totally took that into consideration. And there are vibrating, simple vibrating watches that you can, or timers that you can set a timer to and put on someone's limb. I just felt that the Apple Watch was the most functional in terms of, readily available devices that are worn by not maybe all of the population, but a significant amount of people that we see on a daily basis. When I totally thought of you when I was writing this up in our occupation and our ethics course and thinking about occupational justice, and I was like, oh, but what about those people who can't afford the watch? That was definitely crossed my mind. And you
or the iPhone. I mean, you know, or the Apple products.
Totally. My thought process is, you know, if we have technology that we can use, we should be using it. And you know, that being said, maybe we need to make it more accessible to the general population. You know, not just deciding not to use certain devices because it's not easily readily available to everybody. Although it should be, right? That's like comes back to my teaching philosophy statement. Like, you know, if we have things that can help people, why wouldn't everybody be able to use them?
Right. I mean, this could be something that you could go after Apple to certainly help the people the disabled community in particular, you know, to help them have access, especially if, you know, and those who can't afford it, who need it for health purposes.
Mm-hmm.
So
or team up with an engineer who can make a
just what you need.
watered down version of the Apple Watch.
Yeah.
Right. Right. I mean, this could be your next project.
There is yeah, totally.
Find an engineer and design something.
Right. There's a device like I think Flint Rehab made a watch specifically for stroke and a hemiparetic limb that analyzes like every kind of data, amount of the percentage of time you incorporate your affected limb and all this stuff. But even that's more expensive than the Apple Watch. So it's like they invented this tool that really most of the population can't even use.
Right.
So
Right.
it's about, you know, coming up with something that is accessible for
Right.
everybody.
I was going to say, is there a way you could advocate for the Apple Watch to be a DME that can be covered by insurance so people will be able to access that if they really need it, right?
That's right.
I wish. I have enough time. I have enough trouble getting insurance companies to cover a plastic shower chair.
Jeez. Well, congratulations, Josh.
Thank you.
You did a fabulous job, and congratulations on being a daddy.
Thank you.
And extend that to your wife on being a mom.
I will. Thank you.
All right, everyone, we are actually out of time. So before we wrap this up, and more officially now, because Dr. Focaster initiated it, I want to now officially congratulate and newly mint our Dr. Joshua Kotler. Congratulations, Josh.
Thank you.
Congratulations.
Officially. And so just a quick procedural announcement. So I hope to get your, let me just stop sharing, to get your feedback from your committee, the rubric from your committee within a day. We will send that hopefully by Monday or Tuesday to you for any other finalizing feedback. And then you will have 2 weeks to lock in and finalize your digication, so we could post that publicly and finalize all of your Capstone artifacts into a permanent digital file. And then you're officially done with the program. And again, congratulations. I know this has been a roller coaster of the past 2 or 3 weeks for you, but you finally made it. Now I hope you could sleep. I know you have a long PTO and paternity leave for you, so enjoy the rest of the few weeks ahead, and you're officially done. Congratulations.
Thank you. Thank you all so much. Everyone still on this call, you've all been so, like I said, I'm forever grateful for everybody on this call, and I hope to continue working with everybody in the future, and thank you so much for everything.
Josh, is Eddie your father? I see there's an Eddie Kotler on.
Yeah, he's in his office and someone put it on for him, and he was given specific instructions to stay on mute and probably keep the camera off the whole time.
Well, I think we should congratulate him for being
Congratulations.
and for having a son as a doctor.
He won't know how to turn unmute unless he knows how now. Dad, you're allowed to unmute now.
I can see
Tell someone to unmute him.
Too. Jacob's here. M's brother is here. Hi, Jacob.
Hi everyone, yeah, I'm Josh's brother-in-law. I was in another meeting, so I came pretty late, but Josh, always, I remain impressed by you, by your humanity and your intellect.
Jake is a PhD student at Vanderbilt studying something that I can't even describe to you guys.
Jacob, I liked your kitchen, by the way.
Yeah, thank you. Studio life, graduate student life.
Josh,
Yeah, thank you
go ahead.
guys.
Oh, I think your dad unmuted actually.
Dad, you there?
He's saving it for private.
Yeah, he is unmuted.
That's okay.
Josh, I was just gonna say, I don't know if you could see the chat, but I'm so happy, and I remember back in so many classes, it was, we were outnumbered by our PEDS colleagues and peers, and Josh and I and Scott were like the adult crew who sort of stuck together, and it's amazing to see where the project has ended up. I remember the foundation of just talking about it. So congratulations.
Thank you. And I'll send you all pictures of the baby as soon
Yes.
as I get more.
Yes, please.
And we need to celebrate in person sometime, Josh. Maybe when
I know, soon.
I think if Amanda's still there, you know what happens when you have a baby, you get sucked into bringing all of our PEDS faculty. You know, the babies become...
I'm ready. Party.
Lots of tests, lots of tests.
Party at Dr. Geller's house.
Okay. Have a party in my house when this is all over. We'll do that.
All right, everyone. Thank you all for joining us.
Thank you, everybody.
Hi, congrats.
Congratulations.
Congratulations, Dr. Kotler.
Thank you.
Take care, everyone. Bye-bye.
Bye.